Welcome, future occupational therapists, to a deep dive into one of the most common yet deceptively complex injuries you'll encounter in hand therapy. Today, we're talking about extensor tendon injuries. Tendons? Aren't those just the boring, stringy bits connecting muscle to bone? To which I say, absolutely not. Think of your extensor tendons as the unsung heroes of your hand. They are the sophisticated system of biological cables that allow you to open your hand to wave hello. Release a grip on a coffee mug. Type out that brilliant essay you've been working on. Masters of extension, champions of straightening, the literal force behind letting go. Without them, your hand would be stuck in a permanent fist bump, which, while cool for a moment, is not exactly functional for daily life. These tendons are located on the back, the dorsal side, of your hand and forearm. They are responsible for opening our fingers and wrist. Imagine trying to catch a ball, play the piano, push a door open. It's nearly impossible. That's why, when these tendons get injured, it's a really big deal. It can profoundly impact a person's ability to engage in meaningful occupations, work, self-care, hobbies, leisure. For OT students, this isn't just anatomy memorization, it's appreciating the engineering of the human hand and knowing how to help someone reclaim independence when that system breaks down. Why a whole crash course? Because they come with unique rules and challenges. Unlike flexor tendons, extensor tendons are thinner and flatter. They lie just beneath the skin with very little protective padding, vulnerable to minor cuts or blunt trauma. The delicate, high-performance race car of the tendon world, versus the flexors, a sturdy off-road truck. Treating them requires finesse, deep understanding of their delicate structure, and a whole lot of OT magic. Getting it right leads to amazing functional recovery. In the next 10 minutes, we'll unpack what you need to feel confident with your first case. We'll cover anatomy, how they get injured, injury zones, assessment and intervention strategies, turn confusion into clarity, help clients high-five, wave, jazz hand their way back to life. Grab your metaphorical lab coat and thinking cap. Class is in session. Let's get started on mastering these amazing structures. To truly understand how to fix something, you first have to understand how it's built. So let's pop the hood and look at the anatomy of the extensor tendons. Picture a superhighway of movement running from your forearm, across your wrist, and all the way to your fingertips. This is your extensor mechanism. The journey begins with the extensor muscles, the powerhouses located in the back of your forearm. These muscles are the engines that generate the force. When they contract, they pull on the long cord-like tendons. Voila, your wrist and fingers straighten out. It's a beautiful coordinated dance of biology and physics. This superhighway isn't just one big road, it's a complex network. As the tendons cross the wrist, they are held in place by a thick band of tissue called the extensor retinaculum. Think of this like the overpasses and tunnels that keep traffic flowing in the right lanes. The retinaculum organizes the tendons into 6 distinct compartments, preventing them from bowstringing. Once they pass the wrist and spread out across the back of the hand, they continue their journey toward the fingers. Here they become flatter and wider, transforming from simple cords into a complex interwoven sheet of tissue known as the extensor hood. This intricate net allows fine-tuned, independent movement of each finger joint. Now let's talk zones. The extensor system is divided into 8 distinct zones. Zone 1, fingertip dip joint. Zone 2, middle phalanx area. Zone 3, over the pip joint. Zone 4, proximal phalanx. Zone V, MCP knuckles. Zone 6, back of the hand. Zone 7, wrist. Zone 8, forearm. An injury in Zone 1 is treated very differently from one in Zone V. What makes this anatomy unique is the extensor mechanism's thinness and superficial location. Very little subcutaneous fat or muscle protects these tendons. They're right under the skin. That's why a minor kitchen knife slip or scrape against a sharp edge can easily sever them. Their blood supply isn't as robust as flexor tendons, so healing can be slower and more delicate. Delicate, exposed, and poorly vascularized. A trifecta that makes extensor tendon injuries a special challenge for OTs. So how do these vital structures actually get injured? The causes are varied, but usually fall into a few categories. The most frequent culprit is direct trauma, a laceration, a slip while chopping vegetables, a mishap with a box cutter at work, a broken piece of glass. These are called open injuries. There's a break in the skin. The wound can look small, but the tendon beneath may be severed. That can cause an immediate inability to straighten a finger or the wrist. Another common cause is blunt trauma leading to closed ruptures. The skin stays intact, but the tendon can tear. Basketball hitting the tip of an outstretched finger. Volleyball hitting the tip of an outstretched finger. Forceful flexion can avulse the tendon from bone. These injuries can be subtle and mimic a sprain. That's why a thorough OT assessment is critical. What makes them tricky is the tendon anatomy. The extensor mechanism is an interconnected web of fibers. Damage to one part throws the whole system off balance. Stronger flexor muscles become unopposed and pull the finger into flexion, a deformity. This imbalance drives our therapeutic priorities, protect repairs from constant pull. Healing is another hurdle. We want a strong scar at the repair site, but adhesions, the tendon sticking to skin or bone, are the enemy. Because extensor tendons are superficial, adhesions are common. If the tendon is glued down, it can't glide, and motion is lost even if healed. Rehab is a paradox. Immobilize enough to heal, move enough to prevent sticking. It's a tightrope walk requiring skill, precision, and perfect timing. Okay, let's put on our tourist hats and take a trip through the extensor zones, stopping at the most common injury sites. Our first stop is Zone 1 right at the fingertip, over the dip joint. An injury here is famously known as a mallet finger. This happens when the terminal extensor tendon is either cut or ruptured from its attachment on the distal phalanx. The result? The person can no longer straighten the very tip of their finger, which droops down into flexion. It's the classic, "I jammed my finger playing sports" injury. While it might seem minor if left untreated, it can lead to a more complex problem called a swan neck deformity, where the imbalance of forces causes other joints in the finger to hyperextend. It's a perfect example of how one small problem can cascade into a bigger one. Next up, let's travel down to Zone 3, which is located directly over the PIP joint, the middle joint of your finger. An injury here disrupts the central slip of the extensor hood. This is a big deal because the central slip is the primary workhorse for extending that middle joint. When it's injured, the lateral bands of the extensor mechanism can slip down toward the palm, and the unopposed pull of the flexor muscles causes the PIP joint to pop up through the extensor mechanism like a button through a buttonhole. This creates a classic boutonniere deformity, where the PIP joint is stuck in flexion, and the DIP joint becomes hyperextended. It's the opposite of a swan neck, and is another signature signpost of a specific extensor tendon injury. Now we arrive in the bustling metropolis of Zones 5 and 6, which cover the MCP joints, your knuckles, and the back of the hand. Injuries here are often the result of more significant trauma, like a deep cut or a crush injury. A particularly infamous injury in Zone 5 is the fight bite. This occurs when a person punches someone in the mouth and a tooth penetrates the skin over the knuckle, lacerating the extensor tendon. These injuries are notoriously nasty because human mouths are full of bacteria, making the risk of a deep, aggressive infection incredibly high. Any injury over the MCP joint that breaks the skin should be treated with extreme caution and suspected of being a fight bite until proven otherwise, as infection can destroy the tendon and joint. Finally, we reach Zones 7 and D8 at the wrist and forearm. Injuries in this region are often more complex because you're dealing with multiple tendons, nerves, and blood vessels all packed tightly together. A deep laceration at the wrist, for example, can sever all the finger and thumb extensor tendons at once along with the main wrist extensors. This results in a complete inability to straighten the wrist or any of the digits, a condition known as extensor lag. The hand will droop into a flexed position. Because so many structures are involved, surgical repair is more complicated, and the rehabilitation process is often longer. Each zone presents its own unique clinical picture and requires a tailored approach to splinting and therapy, which is why being a zone expert is so critical for an OT. When a client with a suspected extensor tendon injury walks into your clinic, it's time to put on your detective hat. Your first job is to gather clues. Start with a thorough client history. Ask the who. Ask the what. Ask the when. Ask the where. Ask the why. When exactly did it happen? What were they doing at the time? Was it a sharp cut or blunt force? Did they get immediate medical attention? Did they have surgery? Knowing the mechanism gives immediate insight into what you might be dealing with. Knife slip in the kitchen. Think clean laceration. Punching a wall. Consider closed rupture or possible fracture. This initial conversation sets the stage for your physical exam. Next, observe carefully. Start with a visual inspection. Look at the hand at rest. Note the hand's posture. Is a fingertip drooping? Think mallet finger. Is the whole hand dropping into wrist flexion? Look for an open wound. Look for a surgical incision. Look for sutures. Look for staples. Note swelling. Note bruising. Note redness. Compare the injured hand to the uninjured hand, side by side. After visual inspection, move to hands-on assessment. Extreme caution. If the client had surgical repair, follow the surgeon's post-op protocol to the letter. You'll typically assess range of motion. In early stages, you may be restricted to passive motion only. Gently move joints to check tendon glide and available range. Perform specific tests like Elson's test. Ask the patient to extend the PIP against resistance and watch the DP for floppiness. Finally, assess other key factors that impact function. Test sensation with a monofilament. Assess edema with a volumeter or a tape measure. Ask about pain. Clarify the patient's functional goals. What do they need to be able to do again? Your assessment isn't just about the physical problem. It's about the person attached to the hand. Use that information to create a roadmap back to living their life. Once your assessment is complete, it's time to open up your OT toolbox. Immobilization via splinting is the cornerstone. Splints protect repairs from flexor pull and accidental movement. The type of splint depends on the zone of injury. Mallet finger, Zone 1. Small fingertip splint, dip hyperextension, 24/7 for 6 to 8 weeks. Zone 6. Wrist and hand splint, positioning the wrist in extension and the MCP joints in flexion. Fabricating the perfect splint is an art. Precise molding and fit. Precision matters. An improperly positioned splint can cause skin breakdown. It can cause joint stiffness. It can put too much tension on the repair. You need to become an expert with thermoplastic materials, a heat gun, and scissors. Your goal is to create a device that is effective, comfortable, and durable. Patient education is paramount. Teach why they need the splint. Teach how to wear it. Teach how to check their skin for red spots. And most importantly, to never, ever remove it unless specifically instructed to do so. Compliance is everything. Build rapport to ensure success. While immobilization is key, complete lack of movement can cause adhesions and stiffness. This brings us to early motion protocols. Depending on the surgeon and repair quality, you might start controlled early motion. Approach 1. Immediate passive motion. Therapist or other hand moves the injured finger gently through a set range. Approach 2. Immediate active motion. Dynamic or relative motion splint. The dynamic splint uses uninjured fingers to move the injured one for safe tendon glide. As the tendon heals, your interventions will evolve. Around the 4 to 6 week mark, you'll begin gentle active ROM without the dynamic splint. Make a gentle fist, then fully open the hand. Progress to strengthening with therapy putty. Progress to small weights. Progress to grippers. Work on scar management. Teach massage of the healed incision. Break up adhesions. Improve tendon glide. Incorporate functional tasks like buttoning a shirt. Incorporate typing. Incorporate holding tools. It's a graded, step-by-step process, from protected healing to full, powerful function. Even with the best surgical repair and the most perfectly executed therapy plan, the road to recovery can have its bumps. Complications are real, and as an OT, you must spot them early. One of the most feared complications is tendon rupture. The repaired tendon pulls apart. Causes: non-compliance with splinting, removing the splint and accidentally flexing the finger, lifting something too heavy, too soon. Telltale sign: sudden loss of active extension. If you suspect rupture, contact the surgeon immediately, likely a return to the OR. Adhesions are a major and probably the most common complication. The tendon becomes glued to skin or bone, preventing gliding. Client report: feels stuck. Your observation: active ROM much less than passive ROM. Joint moves passively, but the tendon can't do the work. Primary treatment: more aggressive therapy. Focused scar massage, stretching, specialized splints that give a long, gentle stretch. It's a battle often won with persistence. Joint stiffness is another frequent problem. Immobilization tightens ligaments and capsule, limiting motion even with a gliding tendon. Especially common at the PIP joint. That's why early controlled motion helps prevent stiffness. If stiffness occurs, gentle but firm passive ROM exercises and static progressive or dynamic splinting, low load, prolonged stretch. Be careful, don't overstretch and risk the tendon. Watch for secondary deformities: swan neck deformity, boutonniere deformity, extensor lag, quadrigia syndrome. Recognize patterns, adjust your plan, and advocate, including another surgeon consult if needed. So, after this whirlwind tour, what is the occupational therapist's grand role in the saga of an extensor tendon injury? In short, we are the architects and project managers of the recovery process. The surgeon may be the one who physically reconnects the tendon, but it is the OT who guides that repair from a fragile, vulnerable state to a strong, functional, and fully integrated part of the client's life. Our role begins on day one: creation of a protective orthosis and delivery of critical education that empowers the client. We are the protectors of the repair, ensuring an ideal biomechanical environment. Our role then transitions from protector to mobilizer. We are movement specialists balancing rest and motion. Tissue healing, anatomy, biomechanics, applied to introduce movement precisely to promote glide without rupture. Know when to push, when to hold back, and how to read the subtle cues the client's body is giving you. Hands-on work, specialized splints, and targeted exercises to combat stiffness and adhesions. We are constantly problem-solving, adjusting our plan based on the client's progress. Beyond the physical mechanics, our role is deeply rooted in occupation. We are not just treating a tendon, we are treating a person who has a life to get back to. We are the functional experts who bridge clinical exercises and real-world tasks. We analyze the client's daily occupations, their job, their hobbies, their self-care routines. This might mean practicing buttoning with one hand, adapting a keyboard, or figuring out a new way to hold a guitar pick. We are the creative problem solvers who help people reclaim their roles and their sense of self. Ultimately, the OT is the coach, the educator, and the cheerleader. We build a therapeutic alliance, providing knowledge, tools, and encouragement. We celebrate the small victories, the first flicker of active extension, the first time they can make a full fist, and we help them stay motivated when they encounter setbacks. Our master plan is holistic. It addresses the physical structures, the functional challenges, and the psychosocial impact of the injury. We guide the entire journey, from the initial post-op visit to the final discharge when the client can confidently use their hand again for everything that is meaningful to them. All right, we've covered a ton of ground, so let's boil it all down to the absolute must-know, can't forget key takeaways for every future OT. First, extensor tendons are the superficial, delicate structures on the back of your hand that let you open your fingers and are highly vulnerable to injury. Think of them as the fragile but essential cables for letting go. Second, the zones are everything. Knowing the 8 extensor zones is like having a map of the hand. It tells you what kind of injury to expect and how to treat it. Zone 1, mallet finger. Zone 5, fight bite. Memorize them. Third, your splint is your superpower. A well-fabricated custom orthosis is the #1 tool for protecting a fresh extensor tendon repair. It prevents rupture by holding the hand in a position of rest, reducing tension on the healing tendon. Your ability to make a great splint and educate your client on wearing it is non-negotiable. Fourth, rehab is a tightrope walk between immobilization and movement. You must rest the tendon enough to let it heal, but move it enough to prevent adhesions and stiffness. This is where early motion protocols, whether passive or active, are your best friends. Always follow the surgeon's protocol to the letter. Fifth, and perhaps most importantly, you are treating a whole person, not just a tendon. Your assessment and interventions must be client-centered and occupation-based. The goal isn't just to get 90 degrees of PIP flexion. The goal is to help your client get back to playing the piano or holding their grandchild or whatever it is that gives their life meaning. Never lose sight of the occupation in occupational therapy. These 5 points are the foundation upon which you will build your expertise in managing these fascinating and challenging injuries. Master them, and you'll be well on your way to helping your clients achieve incredible outcomes. And now, for the fun fact you've been waiting for. The extensor mechanism is so intricate that it has its own special connections between the tendons called the juncturae tendinum. These are small fibrous bands that link the extensor tendons of the index, middle, ring, and small fingers on the back of the hand. You can see their effect yourself. Try this. Lay your hand flat on a table and tuck your middle finger underneath your palm. Now try to lift your ring finger straight up off the table. It's almost impossible, right? That's because the juncturae tendinum are tethering your ring finger's extensor tendon to your trapped middle finger tendon. It's a built-in anatomical quirk that demonstrates just how interconnected this whole system really is. Thank you for tuning in.